on this episode of A Tale of Two Hygienists.
If we are in the same practice for a long time, we grow with our patients, right? And so we may know that they're thinking about starting a family, and those are the kind of conversations that you can have ahead of time. If they have any work that needs to be done, a heads up about what the changes in their home care could be because of dietary changes or because of nausea and vomiting. And you just kind of feed those little pieces in ahead of time. There's a direct correlation with, the bacterial load, inflammation, and potential of those adverse outcomes, which would be low birth weight and a preterm birth. And that comes with its own plethora of concerns for the baby, for mom. So we want to do everything that we can in our collaboration with medical professionals caring for the mom to eliminate any of those risks.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 461. I'm your host, Andrew Johnston. In this episode, Annie and I get a chance to sit down with Sue Scherer. Sue is very quickly becoming one of my favorite people in dentistry. She's so much fun. She's so smart. She does so well at just discussing her points very eloquently. And in this episode, we talk about one of her passions, one of her strengths, which is pregnancy and oral health. It was a nice episode to have because I feel like sometimes depending on, your demographic and the types of patients that you're seeing, either you're going to see an abundance of pregnant patients or it's going to be kind of sporadic. And it was a nice refresher for those who maybe haven't had very much exposure with patients who are pregnant in some of the concerns that you should be looking out for, some home care tips and tricks, and all of the good stuff. And so we're very happy that Sue was here to share that with us. And then next week, we have an episode with Tom Marler, and it's an episode that's focused around office culture. I feel like, I think you all know me. I love DSOs. DSOs are great, but not all DSOs are doing it right. And the ones that are doing it, there's something magic that they're doing that they can get all of their offices to enjoy going to work, to do the right thing for the patients. And, the side of that is also the hygienists are making really good money there. And so we talk about what they've done to kind of grow everything and keep that accountability, keep that happiness, and keep our patients healthy and safe. And so that's a really good episode too. So make sure you guys come back next week for that episode. That's it for this week. If you guys have any questions, make sure you send us an email, andrew@ataleoftwohygienists.com. We'll talk to you then.
A tale of two hygienists.
Listeners, welcome into the interview portion of the podcast. Joined today again by Sue. Sue, welcome back to the show.
Thank you for having me back.
First of all, do you love how I was like non-podcaster voice and then I turn it on?
Yes. Yeah.
Voice.
Shifted.
Yeah. That was
I heard that.
weird.
Yes.
I kind of want to not do that. Anyways, welcome back. We're really excited to have you. Annie's super excited. She's beaming over here.
I am. I'm very excited to talk about this today.
Yeah.
Well, and then last time you were on, you're like, hey, I want to come back on. I'm like, okay.
yeah,
twist our arm. Let's go.
I know. Seriously.
Well, thank you. I appreciate you having me back and to share about some of these topics that I'm really passionate about.
Well, and also, and look, listeners, you're not going to care about this part, but I shared with you, I think the numbers, like your episodes do really well. People like you. Like you come off very well. And so,
Sue.
Thank you.
Wait for our audience for this episode. Like they're in for a treat. Today, we're talking about pregnancy. And this is something that like you said, you're really passionate about it. It's something that you actually do present on. I think we're going to try and touch on some of those points. But I think, listeners, before we get into this, like Sue's got a lot that she has that she wants to share. Make sure you look her up or reach out to her if you have specific questions, but also find out where she's speaking and presenting these great topics on, because we just can't cover it all in the next 20, 25 minutes. So.
Yes. Okay, Sue. I know there's so many things that we want to talk about today, but I think first and foremost, let's talk a little bit about what do oral health changes look like in pregnancy as providers? What are the things we're looking for?
Yeah, I think, so it's so easy for us to know, right? Okay, we're going to see potentially inflammation and bleeding.
Yeah.
But other things that, we're looking out for, periodontitis, we're looking for pyogenic granulomas, erosion and decay. And we can even, in some cases, see tooth mobility. Those are common, but most commonly, we're going to see inflammation. We're going to see gingivitis. It's like 60 to 70% of women have pregnancy gingivitis. So that's a large percentage of our patients.
And I feel like it's such a spectrum because I know like when I've seen pregnant women, some present like very obvious signs and some present none. And
yes.
so
And it comes down to our home care, right? We know that's such a huge part. Gingivitis is reversible. But during pregnancy, the hormonal changes that are taking place, and it's primarily estrogen and progesterone changes that are taking place, and there's an increase in those hormone levels. And so that's what drives. There's an increase in capillary permeability. And so that's why we see inflammation and bleeding during pregnancy that maybe we didn't see before. But some of you might think of the saying, right? One lost tooth for every baby. Have you guys heard that? Patients ever say that to you?
I've actually never heard that.
You've not heard that?
No.
Oh, man. I don't know. You might be making me feel a little bit older here, Annie, but that's definitely something.
Never heard this.
Yeah. So it's a common thought. People say like, oh, the baby, they'll say things like the baby steals all of the calcium. And so you lose a tooth, or the baby, I lost, not me, but I've had patients say like, I lost a tooth for every baby that I had. But when we stop and we think about pregnancy, one of the things that changes for people is their diet. And, that comes with cravings, and it comes with the body's need for other nutrition that maybe they don't crave normally. It also comes from habit changes, right? They might have been experiencing nausea and vomiting. And so they're doing things like sucking on lemon drops all day long or eating saltine crackers so that they don't feel physically ill. And so now they're not brushing their teeth every time that they're popping a lemon drop or eating those saltines that are next to their bed on their nightstand, right? And so that's the driver behind those changes that we see with erosion and decay, not the baby itself.
Well, it's interesting though, because I think some of those go hand in hand, right? So I think dental professionals understand, hey, they're going to get some cravings. The nutrition's going to be different. That's all these things. But when you also change your nutrition, we're learning so much more about going back to that permeability of the capillaries. Like we are causing through our bad nutrition or maybe unhealthy habits, an increase in that inflammation, which is going to perpetuate the problem. And some people, their immune system can weather that, right? Some people are not. It's a gradient, and you just never really know which of these factors is going to be the trigger. It's hard to have that kind of like comprehensive conversation with our patients in such little time.
Yes, that is so true. And, knowing too, depending upon when you might see a patient during their pregnancy, they may already be through the first trimester where they had a significant amount of vomiting, for example. And so we might miss a little window of some of the education. But one of the things that I learned to do in my research is that patients who are vomiting, they really should be rinsing afterwards with a baking soda mixture. So it should be 1 teaspoon of baking soda into a cup of water. And that's so important because if we are in the same practice for a long time, we grow with our patients, right? And so we may know that they're thinking about starting a family. And those are the kind of conversations that you can have ahead of time, if they have any work that needs to be done, a heads up about what the changes in their home care could be because of dietary changes or because of nausea and vomiting. And you just kind of feed those little pieces in ahead of time. Of course, that's in an ideal world, right? We don't always have that opportunity, but it's a good conversation to have too. And for some women, it lingers. And so, still having that conversation. How are you doing? Are you experiencing any nausea and vomiting? I have some recommendations for you if you are.
Let me ask for the listeners that might have missed the episode. We talked about baking soda in a previous episode to kind of help maybe dispel a myth or whatever. Is there any concern with, the baking soda water having an interesting taste or an interesting texture or something that's going to maybe make the problem worse?
I would think, this is kind of going off of me, but I would say no. It's actually going to be easier to tolerate, I think, than a saltwater mixture would be. And it's not abrasive. We talked about RDA values, and the RDA value of baking soda is 7, but then now you're dissolving it into water. So you don't have a concern for that. The benefit of baking soda is it's going to neutralize the pH in the oral cavity. And that's huge when you have somebody that's experiencing nausea and vomiting, because their risk for erosion and decay goes way up. So this allows them to neutralize. And what I failed to say just before is that they should not be brushing for at least 30 minutes after vomiting. And what is that? For most people, right? You get sick, and what's the first thing you want to do? You want to brush your teeth. Yeah, you don't want to taste that. And so when we can have those conversations ahead of time, it's really helpful to the patient to help to eliminate the risk factors for erosion and decay.
I think sometimes Annie would probably know this way better than I don't know why I'm even talking on this episode, but I feel like vomiting is sometimes you can expect it, right? And during pregnancy, and sometimes it's just completely unexpected. Is there any benefit to having a pre-mixed something, or does the baking soda separate out and you have to remix it? I mean, I'm trying to think how can we make this so easy for our patients that they can just go ahead and neutralize their pH real quick?
Or how do you feel about, on top of this, you can respond to what I'm going to say as well. How do you feel about pH elevating spray? I know there are companies that make sprays.
I would think that sounds like something it would be easy. I'm not knowledgeable on that product, but I would think that would be something easy for the patient to carry, right? You think of a patient that has a dry mouth and they can just spray to have immediate relief. But I think a baking soda water mixture is so quick to do. But to your point, Andrew, if they're out and about, that's a little complicated. So maybe having something like Annie's talking about, a pH balancing spray, something of that nature that's quick and easy. Yeah, why not?
Okay, so in addition to that, we were talking about neutralizing the pH of our saliva and pregnant women being at high risk because of vomiting early in pregnancy. What other home care recommendations do you have for our pregnant patients?
I'm all about what's going to work best for the patient, right? So I found that in my 20 years chairside, there were certain things that worked really well for women during their pregnancy. So one thing would be to, if they're having difficulty brushing their teeth, how can you navigate around that? So if it's triggering a gag reflex, what's triggering the gag reflex? Is it the toothpaste? So if it's the toothpaste, is it just the flavor? Is it mint? Can they use a different flavor toothpaste? If it's not the toothpaste, right, or if even switching flavor it's the texture of the toothpaste that's triggering, then can they dunk their toothbrush into an antimicrobial mouth rinse, something that's going to, or some other type of mouth rinse that's going to give them benefits that they need? What else could they do, right? You might find that a patient, strong gag reflex, putting their hand into their mouth to floss, that's complicated. So what other interdental cleaning options do you have for them, right? Can you recommend floss handles? Can you recommend interdental brushes? Can you recommend a water pick water flosser? There are different things for different patients. And there's different advantages to all of those. So exploring with the patient, it always comes down to, with home care, having a conversation. What's working for you? What's not working for you? What are you willing to try? Get to know the individual and their lifestyle and how you can help them to navigate, because there are so many options out there to help them have optimal oral care.
Let's talk a little bit about when a patient comes into the chair that's pregnant and presents with whatever increased inflammation or signs of periodontal disease. What is treatment looking like, as far as I'm more so talking about local anesthesia, nitrous, scaling and root planing. What are the guidelines and parameters around that?
Yeah, that's a really great question, because I think this is the area that causes the most confusion for dental care providers. You'll see, on social media conversations like, oh, you have to get a clearance form, or the doctor wanted a clearance, or, and that, I don't know where that came from, but that's made up. Patients, according to the American College of Obstetricians and Gynecologists, it is safe to provide preventative, restorative, and diagnostic care to our patients at any phase of pregnancy. So it doesn't matter if they're in first, second, or third trimester, we can provide care to them. And even if they have a high-risk pregnancy, I would say, unless they're on bed rest and, you can see them if they're willing to come in, if it's a good time of day for them. Again, I'm going to jump back to that patient that might be experiencing nausea and vomiting. You might want to schedule at a different time of day. They might say, morning's really rough for me. My appointment's at 10, but I'm not going to be able to sit through the appointment. Can you accommodate them and move them to the afternoon? So scheduling accommodations. But then when it comes to providing care, it really is safe. So again, that preventative, diagnostic, and restorative. So as far as preventative, scaling and root planing, if you have a patient that has periodontal disease, there is research out there that providing the scaling and root planing will not result in an adverse outcome for the pregnancy. So, but we know having inflammation, having a high bacterial load, those can have adverse outcomes. It can result in a low birth weight. It can result in a preterm birth. So if we can help our patient by providing that care and getting them in a good self-care regimen, not resulting from scaling and root planing in an adverse outcome, we could potentially have a healthier pregnancy for the patient, right? As far as x-rays are also recommended. The American College of Obstetricians and Gynecologists also say that x-rays are safe during pregnancy. And I know that can be a controversial topic for many people, but with that, it's not that you're going to go in and necessarily take a full mouth series, right? You're going to use ALARA principles as low as reasonably achievable. And I really hope that everyone's using that principle with x-rays, no matter what. And that's a whole other conversation we can have. But with your pregnant patients, right now, the regulations say that the patient that is pregnant should be shielded. Now, I know that there's some new conversation about recommendations around shielding, but at the end of the day, we have to follow what our regulation is. So if your governing body, so for example, I'm in New Jersey, we are regulated by the New Jersey State Board of Dentistry. They say we need to shield our patients for x-rays. Until that changes, in New Jersey, we'll be shielding. So for right now, the regulation for pregnant women is that you would shield them for x-rays. So use your clinical judgment, right? You have a new patient that comes in. They've been seeing the dentist every 6 months. They're not reporting any problems. Do a hard and soft tissue examination. Make the determination, can x-rays wait until after the baby is born? Or maybe you have a new patient and they're presenting and you see a concern, right? How many times have you had a patient sit in the chair and you find a fistula and the patient didn't even know anything was going on? Use your clinical judgment, take an x-ray that's localized. And that we could do case studies for hours on that topic, but it's about finding out what is best for the patient. You also asked, I feel like I'm just going
No,
here.
this is good.
So if you have questions as I'm going, please interrupt me. But when we think about nitrous oxide can be great to manage patients' anxiety. It is a contraindication during pregnancy, not just for patients, but for the provider as well. So with our patients, we need to find another way to manage their dental anxiety or concerns that they have if they need treatment without nitrous oxide. It can cause fetal harm, and so that is why it's contraindicated. For the pregnant provider, it's recommended that they not be the one administering. So if you're a dental assistant, if you're the dentist, if you're the dental hygienist, that care with the nitrous needs to be provided by somebody else on the team.
Is it an absolute contraindication or is it a relative contraindication? Is it absolute?
It is, from everything I have read, it is an absolute.
Okay. I know, and it's interesting because
during birth.
No, go ahead.
Is that what you were going to say? They're using it during birth? Somebody asked me about it recently.
I feel like I saw something recently that it was like a relative contraindication. But anyway, I always thought it was absolute. I just thought I saw somewhere it was relative. And then, yes, on the flip side, I know they're outside of the U.S., they will offer nitrous oxide during birth.
Yeah, the ADA says it is a contraindication, and those are by, there's some deep standards that you could get into if you research on that it should not be used on pregnant women.
Yeah, I remember I asked my OB when I was pregnant about that, and she was like all for nitrous, and I think more so just probably from labor, because I was like, I'm practicing clinically, like I need to be aware of this, and she's like, no, nitrous is great. And so I'm like, I don't know, you just get those different perspectives, and I'm like, well, from my understanding, nitrous during pregnancy is a contraindication. So
yes, and the concern is fetal harm, and so yeah. Mm-hmm.
Okay.
I think there are other ways in the dental office that we can manage patients' anxiety, and that might be needing a partnership with the OBGYN, right? The patient might need to take a medication that needs to be prescribed, and so that conversation would absolutely tie in their OBGYN.
Sure. with on top of nitrous, is it more of a concern for just I'm talking about for the provider when they are pregnant, if they're in their fertile years as far as wanting to plan for a family, is nitrous still a concern to be around?
That's a great question. And I have not read on that, but if the contraindication is fetal harm and the individual is not pregnant, then you don't have that protection to worry about. But hey, maybe that's a research topic for someone. I don't know.
Yeah.
Right.
Okay.
You also asked about anesthetic.
Yes.
So for anesthetic, it's recommended that lidocaine be used, and it can be with or without epinephrine. So anybody who is certified to give local anesthetic, there are, again, regulations out on that can be read. And I know the ADA has that on their website. The American College of Obstetricians and Gynecologists has information out there as well that could be looked into.
Does the maximum recommended dose change when you're pregnant, or does it stay the same?
That's a great question. So I know it says up to 5 tubes containing epinephrine, and then it says up to 10 tubes without epinephrine.
Okay.
If that helps answer your question.
Yeah, it does. I know.
Okay.
I when you were talking, I was thinking I was working with a dentist one time, and she was like, completing scale and root cleaning and getting the patient healthy while they're pregnant is the best time, because once they deliver the baby, they're going to be so busy and they're not going to have time to come into their appointment. So you should just take care of them now. But more so on the effect of what you were saying as far as getting the patient healthy, so that way improving birth outcomes and all that is so critical.
Yes. Yeah. And there's a direct correlation with, the bacterial load, inflammation, and potential of those adverse outcomes, which would be low birth weight and a preterm birth. And that comes with its own plethora of concerns for the baby, for mom. So we want to do everything that we can in our collaboration with medical professionals caring for the mom to eliminate any of those risks.
I know you had mentioned earlier in our discussion, as far as the changes we're seeing oral health wise are pretty much a correlation of changes in hormones. Are you also seeing the similarities with other HRT, like hormone replacement therapy, and patients on oral contraceptives? I know it's not directly pregnancy, but if we're just talking about hormones, are you seeing similarities oral health wise?
So hormone replacement therapy, actually, I expanded this course into a women's oral health course, and I talk about menopause. And individuals who are over the age of 65 who have had hormone replacement therapy have it's something like a 45% lower risk of periodontal disease than women who did not have the hormone replacement therapy, which I thought was very interesting.
That is interesting.
Yes, I would need to do more research on, I wouldn't be doing the research. I'd need to read more research on oral contraceptives because I'm not as familiar there. But anytime you're affecting those hormone levels, whether they're increasing or they're decreasing, we can see an effect orally. When we look at young women in their adolescent years, their hormones are changing. We see things like inflammation. We see canker sores. We see aphthous ulcers, using the street slang there. But, we see those changes, and it's hormonally related. Same thing with pregnancy. We see an increase in the female hormones. Again, estrogen, progesterone. We see an increase in inflammation and bleeding, and then during menopause, we see a drop in the hormone levels. And so we see things like dry mouth experience, progression of bone loss, periodontal disease because of those hormone shifts. So, with the oral contraceptive, it could potentially have a benefit. Some women take an oral contraceptive because they have other concerns, not just pregnancy prevention. So again, that's me making an assumption without having read into that, but I'm sure there's probably information out there.
I was just thinking about the hormones. So
yeah,
anyway, that's a really, really great thought. Okay. Well, Sue, thanks so much for all of your insight. If our listeners have more questions or want to chat with you more about this topic, where can they find you?
So they can find me 2 places. They're always welcome to email me. And it's, I think Andrew will probably drop that into
In the
the
show notes.
show notes. But it's Scherer, which is SSCHERER at Waterpik, which is WATERPIK.com. And I'm on Instagram, so I am definitely not a social media influencer, but I am growing my little following. So if you want to know where I'm speaking or what I'm up to or what state I've been in recently, I'm hanging out over there, sharing what I'm doing professionally. So it's Sue Scherer, Waterpik RDH on Instagram.
Great. Thanks so much, Sue. We really appreciate you being here.
Thanks for having me again. It's great to see you guys.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.